Okay. Good morning, everybody. My name is Christian Theodore. I'm Christian Theodore. I'm one of the PGY 2 months. Guess we'll get started. This first case is a case of Dr. Komatar. It's a 38-year-old male who began experiencing 3 weeks of what he reported as balance issues and a series of falls. He had no significant past medical history. When he was referred to the office, he had no appreciable deficits on physical examination at the time. And he came with this CT scan. So let's see, Victor, what can you tell us about this CT scan?
Axial series CT scan, non-contrast. There appears to be some evidence of more importantly, there seems to be some sort of right-sided mass, possibly intraventricular on the right side, that is potentially creating a hydrocephalus for signs of temporal horns.
Excellent. Okay, good, very good. Yeah, and it's not just the temporal horns. You can look at the frontal horns here; they're kind of plump, and then the atrium here are kind of big. I mean, I'm sure you can measure this and use the measurement method, but it's pretty obviously hydrocephalus. So what do we do next after this point, Victor? What would you do next?
MRI with and without.
Okay, perfect. Okay, so Victor gets the MRI scan, and we see this. So Victor, I'm going to stick with you since you're so good at this. Why don't you tell us what you see?
Across the series, you see a well-circumscribed lesion on the right, intraventricular lesion, homogeneous, and it's not particularly contrast enhancing. That is likely the cause of the hydrocephalus as well.
Okay. Do you think this is an intraventricular mass, or do you think this is an intraaxial mass? Where would you say it's coming from?
Intraventricular.
Okay. So it's really an intraaxial mass, I think. And what is this? I don't know. Can you see my cursor on it? What area is this?
The basal ganglia.
Go up a slide. Oh, sorry. Hold on. This is stopping me here. Maybe. I guess I only have it. Here we go. So, I guess look on the coronal and tell me where you think it's coming from.
Oh, okay. No, this coronal definitely it looks more intraaxial than intraventricular.
That's right, thalamus. Yes, this is thalamus. So, what do you think this mass is like? What give me a kind of a differential.
Intrathalamic masses, I think, primarily include gliomas. The primary ones I can think of.
Yeah, and so, you've got two problems here, and I kind of skipped past that slide, which you identified already. There's two problems. You have a mass, and you have hydrocephalus, and you can see on the bottom CT scan, is the fourth ventricle big or is it small? Small, right? So it's not one of these cases where there's global hydrocephalus. It's not something like that. So it's pretty obvious where the hydrocephalus is coming from. So let's see who else is here. Eva, what do you think the treatment for this should be? Like, what are our goals here?
So the goal is to get tissue and then also to treat the hydrocephalus. And so I guess for the surgical plan, I mean, I don't think it's that you can do gross total resection given the location of the lesion. And so I would just probably do a biopsy here, and then you can try to do an ETV if possible. But it looks like if you look at the sagittal cut on the CT, there's not that much space in the prepontine area, and so it may be hard. I would just look at the MRI and look to see if there's space on the sagittal. So yeah, you could either do an ETV, but if not possible, then you can do a shunt.
Yeah, perfect. So that's what I was alluding to when I was showing these images. So there's not really a lot of room to do an ETV. And so that's, like you said, you need tissue and you need to get CSF diversion. So ETV is probably a little more treacherous and probably not a great idea in this case, like you mentioned. But what's one other thing? I put the coronals up also for a reason. There's something else I'm showing on the coronals that you might want to add to all of everything you just said, which was correct, that you might need to do during surgery. One other little kind of icing on the cake maneuver.
I guess it looks like maybe one of the ventricles is a little trapped. So the right ventricle looks like it's trapped, and so you may have to like fenestrate the septum.
Yeah, exactly. Septostomy. So this cut here is kind of showing, this is the foramen Monroe on the left side, and this is there's really no foramen Monroe on the right. And you can see them both on the CT and also the MRI scan. So if you just drain the one, you're not guaranteeing that you're going to get drainage from the whole right-sided system. So that's exactly right. You need the septostomy to kind of connect the two, even if you are going to divert, because otherwise you'll get a trapped right-sided ventricle. Okay, so we talked about that, and that's sort of what was done. They did endoscopic fenestration of the septum. They did a tissue. They did an endoscopic biopsy of the mass, and then they also put in a shunt, which you can see here on this scan. Okay, and what else? I think that's pretty much it. Okay, I guess we'll go to Dr. Goltekin.
So here you see increased glial cellularity. This would be histologically classified as a lower grade infiltrative glioma. It's a great example of the contribution of molecular pathology. So again, I can make an analogy, draw an analogy between this situation and diffuse intrinsic pontine gliomas of childhood, which is going to be a relevant discussion when you see the molecular results. So here we don't see any necrosis, we don't see vascular proliferation, we don't see really increased mitosis. So this looks like a diffuse astrocytoma. Okay, and then the next slide. This is the mutation-specific immunohistochemical study of histone acetylation element H3K27M. Now, this is positive, which is this is supposed to be nuclear, and you can see all tumor nuclei staining. The blood vessels do not stain, which is serves as an interesting, intrinsic control. So to make a long story short, this slide shows you that this particular tumor is mutated. Therefore, the diagnosis changes to diffuse midline glioma, H3K27M mutated. And that is associated with inferior outcomes in both high-grade and low-grade histology. That's it.
Okay, so let's go to the next slide. So yeah, like Dr. Goltek had said, this is a tumor that's kind of relatively recently been recognized, but it's been a pathological entity that people have kind of realized over the years anyway, that DIPG, or what was called DIPG, has a despite its kind of lower grade histology, that its clinical characteristics are more aggressive and the outcomes are much poorer. Diffuse midline glioma was added to the WHO classification in 2016. You see it along the midline. It doesn't have to be right in the midline, but frequently see it in the brainstem and the pons, specifically in children. But you also see it in the thalamus, like in this case, and then also you can be in the spinal cord too. Even though the histology can be graded lower, the WHO grading on this is 4. And sort of as we've mentioned, you do see it more in children than adults. I remember being at Children's and seeing a case very similar to this. Isn't that case, but a very similar case to this. I think was Dr. Niazi. We got consult for a child who was basically in extremis and hydrocephalic, and over a series of MRI scans, probably like 5 or 6 over a period of like 2 weeks, you could see this tumor just rapidly growing. Very similar. I mean, almost very similar to Dr. Komentar's case, where there's no enhancement. It doesn't really look that aggressive. but just the growth of it is truly astounding. And ultimately, we did biopsy that, and it was the same thing, just like this case. It was an H3K27 mutant, and what that it refers to is a mutation in one of the histone proteins, which is really just and it results in overexpression of this protein EZH2, which has also been found associated with other tumors, and is linked with poor prognosis. And sort of as Dr. Goltek was mentioning, and this case is actually a very good example of it, is the difference in pathology. So, David, you're on, right? Why don't you tell me which of these do you think is the most aggressive histologically? Like, which one looks the worst? Is David on? Maybe Damien.
The one on the right.
Yeah. What is the one on the right, do you think?
GBM.
Yeah, exactly. So that's a WHO grade 4. So then, which of these two? What these two look very similar, right? The two on the left. So what's the one in the middle? Do you think? Do you think that one's worse or less worse than the one on the left?
Worse.
You sure?
No, but I'm gonna stick with it.
Well, no, yeah, I'm not sure either. That's the thing. You're not sure. So this is a pilocytic astrocytoma. You've got this fibrillary background. You've got some Rosenthal fibers, but then this is the midline glioma. This is one of those cases, and you can see that how these two look very similar, but the GBM doesn't look similar at all. I mean, there's a clear difference, but yet the WHO grading is much higher for the midline gliomas. And here's a study just kind of showing how much that really affects the overall survival in these cases. So this is comparing different grades of astrocytoma, whether they've got H3K27 mutation or not. And you see here in diffuse midline glioma, you see there's a huge drop off in with between wild type and mutant between 78 months and then 17 months. And the same thing here, just median overall survival just purely by the mutation alone. It's a huge drop off. And then, like I mentioned, this protein EZH2 with high expression, it's even worse of a prognosis. So it really makes the molecular pathology really makes a big difference in the grading of these tumors. I had an unusual course. She developed blurry vision on the right eye and then had sudden vision loss. So she finally went to an ophthalmologist, got bounced around for I think a couple of weeks, and ultimately made her way to an ophthalmologist who recognized what was going on and sent her for MRI scans. On exam, she had really good vision in her left eye, but her right eye had 20/40 vision, and then some optic disc pallor, and she was slightly proptotic, but her extra-ocular motions were intact, and she had a conjugate gaze and no significant past medical history. So here's her MRI scan. Why don't we get is Adam there? I see Adam and Vignesh. I'm not sure who's who, but why don't you guys can tag team this, whoever wants to go. Adam.
I take this one.
Okay, go for it.
So
What are we looking at?
So we're looking at a right-sided T1 hyperintense lesion, lateral to the clivus, inferior to the temporal lobe. It's extra axial. Is this like a meningioma? Maybe on my different call?
Yeah, perfect. I'll just give you a couple little things here. So it's really a kind of iso-intense. This is T1 without contrast. This is T1 with contrast. So this is you'd say this is a T1 iso-intense lesion on T1. It's extra axial. It's contrast enhancing. It's abutting along the sphenoid bone. It's abutting the cavernous sinus, and it's really extending into the orbit here. I don't know if you can see that on your screen, but you can see it on the non-contrast. And again, finding consistent with meningioma. So she got, again, bounced around, and vision progressed even further, and then ended up with this second scan approximately 2 months later, where the lesion had actually grown slightly, and you can sort of see that along the sphenoid bone here, and then also in the orbit. So she was referred to Dr. Morkos, who did a resection with a cranioorbital approach, and this is the pathology that was returned.
So this slide shows bone tissue, and the marrow space is invaded by islands of meningioma. And there were some other slides too, right? Please, next one. Yeah, so this is another specimen. You can obviously see the red or pink segment of dura here, which also has small islands of meningioma, and attached to the dura at the bottom right is the big purple meningioma tissue. Under high power, you see usual microcystic meningioma that again does not have the known malignant or atypical attributes such as necrosis, increased mitosis, prominent nucleoli, small cell formation, and the like. So this looks like a low-grade meningioma.
Okay, so I added this one. This one's relatively straightforward pathologically. It's just a meningioma. They're slow-growing extraaxial tumors arising from the arachnoid cap cells. Like Dr. Koltekin said, this is a benign lesion, but there are more aggressive ones, which we'll talk about in a minute. Most of them do not grow over appreciable time spans, so we end up watching them for years even. They're usually found in these dural covered areas, which is why we have the specimen from the dura, but they're also found in other areas like the atrium of the lateral ventricles. They could be intraosseous as well. And then some of them are invading the bone or invading the dura, as we just showed. Here's the locations breakdown by percentages. Most of them parasagittal versus convexity. I think most people kind of colloquially say the convexity is the most common location, but there are all these other locations as well. They're kind of found everywhere. And like Dr. Koltekin alluded to, there are multiple different types. So this is a microcystic meningioma, like Dr. Koltekin was saying, but there are these other aggressive types as well. And these other aggressive types do come up on the written board exam. They do ask, what are the more aggressive subtypes, and you have to identify them. These are them, specifically these three. As far as that slide goes. So here's a really classic picture you might see on the written board exam. This is Samodus Meningioma. There's these huge whorls of samoma bodies, which is pathognomonic of meningioma. This picture is almost like a too easy of a picture, but you get the idea that these big samomas are the real kind of hallmark of meningioma. And on the written board exam, they're not going to give you a complicated case. It's going to be fairly obvious like this. And I think if we talk about meningioma, I think there's something else in the differential. I think David will give this to you as well, but there's something else. If the pathology came back as this, what would you say about this? Do you think this is a meningioma or no? Is David there? Maybe we'll bump it up. Who's here? Sumed, you there?
Yep, I'm here.
Yeah, so we're talking about meningiomas. If let's say we don't get this pathology, same scan, same thing, same case I just showed, and you get this instead. What are you thinking? I'll give you a hint.
Look.
What is that? Do you know what that is, Sumed?
Is that an elk?
Close. It's a red stag. It's got horns.
Red.
It's got stag horns.
What in the histology?
Yeah. I mean, stag. It could very well be hemangioblastoma as well. Sorry, hemangiopericytoma.
Right.
Yeah, as a
And I think Dr. Goltekin's probably waiting to scold you for calling it that, but the nowadays people are saying solitary fibrous tumor is kind of the technical name that's been adopted. Hemangiopericytoma still does show up in our boards and various other neurosurgical texts, so I've left it that where we frequently refer to it as that. But this is a slide very similar of hemangiopericytoma, and you see these staghorn vessels, which is the kind of hallmark of that disease. And again, you see a huge difference between the whorls of a Samoma body and then the staghorn vessels of the hemangiopericytoma. So it kind of illustrates the importance of the histology and identifying these two, because they will show very similar lesions. Although hemangiopericytoma can metastasize outside the CNS, and that's it. Makes sense. I think it's pretty. It's a good slide to remember for especially for written boards, because it's going to come. This will come up and they'll ask you to identify this. This is kind of a classic slide.
I want to add that nowadays we can diagnose hemangiopericytoma positively with a single immunostain. If it is positive, it's this called STAT6, STAT6. Then this is definitely a solitary fibrous tumor / hemangiopericytoma. So there's no guessing anymore. There's no indirect diagnosis. There's a direct positive diagnosis of this tumor available by STAT6 immunostain.
Okay. All right. Thank you, Dr. Goltekin. Now, I'm sure that probably will show up. So some of these things do show up on the boards as they get updated. So good one to know. This is the next case. This one is one of Dr. Levy's cases. It's a 72-year-old female complaining of right lower extremity pain. She's got aching, throbbing pain, lower extremity, numbness down the leg. I've included her pain diagram from the clinic, which is, somewhat obvious what's going on, or you would think. She has no significant past medical history. She does not have diabetes. She's just been referred. She's got no imaging. What do we do next? Let's see who's here. Who hasn't gotten chosen? Michael Silva. I see you hiding.
Yep.
All right. What do you think? Just with this, what do you think?
So right lower extremity pain and numbness could be something involving the lumbar sacral spine. It could be the lumbar plexus, peripheral nerves. So yeah, could consider EMG studies, could get lumbar imaging.
Yeah. Okay. Well, she remembers that she did get an MRI scan. She whips this CD out of her purse and says, here's this. So here's this scan. Why don't you tell us what level is this that I'm showing on the right, and then tell us what you see.
It looks like you're at maybe L5, L4, 5 there. It looks like she's some mild degenerative changes, no significant central stenosis.
Yeah, I won't make you belabor it. It's basically a negative scan. So this is 5-1. You can see the sacroiliac here, but there's nothing here. That's what I'm kind of getting at. It's a negative scan, or a relatively negative scan. So disc heights are preserved. There's no stenosis. So it's unlikely that this is where the cause of the problems are. Okay, so you call the physician back and you say, what the hell? Why is this? Why did you send this to me? And the guy's convinced. He's convinced that this is is a neurologic problem and you need to see it. So where should we look next? And I think you kind of already mentioned it. There's other places along the path of the nerve that we can look as well. So I put up her pain diagram, and she's also complaining. I think she, these pain diagrams are good to kind of give you a global idea, but sometimes these patients don't always include everything, just like she didn't tell you about the disc. She's got pain along the bottom of her foot, in addition to what she's drawn on the not pain, really, not, let's say numbness on the bottom of the foot, in addition to the to the lateral leg symptoms. So what do you think about that kind of a distribution? Do you think lateral leg pain and lateral leg numbness and plantar numbness are really like a nerve root injury issue, or do you think they're more of a peripheral nerve issue?
I mean, it could fit an S1 distribution.
The
So
lateral
I think
foot.
it's hard to say.
I think lateral foot, lateral leg. She doesn't have anything in her
Yeah.
butt at all. There's nothing in her butt.
Then it's more likely a peripheral nerve issue.
Yeah. So let's just think about it for a second. So she's got lateral foot symptoms. That's kind of sural distribution, but she also has plantar issues as well. So you're already talking about two things. So you're talking about if you work yourself from distal to proximal, you're talking about, is this tibial nerve involvement or is this common peroneal? So you got to kind of figure out, but it's really both. So we got to kind of narrow our differential down. She doesn't have pain. She's not really drawing posterior leg pain. She's really trying to show lateral leg pain. So, and if, you know, these diagrams again are not always perfectly accurate, but you notice the thing she has, her upper thigh and her butt. So realistically, her pain's kind of starting more here. And that kind of makes sense. If you've got a lesion here, she's going to have involvement of both common peroneal and tibial nerve. So anyways, you're smart, so you order imaging in this location and you find this. Tell me what you see.
It looks like a heterogeneously enhancing lesion just behind the like the lower part of the femur there, kind of above the popliteal fossa.
Yeah, and what's this?
Peripheral nerve sheath tumor.
Yeah, well, this probably likely is, but this is the nerve, probably the nerve proper.
Oh, sorry,
okay.
Interior mouse.
Yeah, sorry. So right, exactly. So let's see, what are we gonna do about that? So we take it to surgery. Okay, this is similar intraoperative imaging to what was seen. So let's talk about what we're looking at here. So this is what? The tumor, right? And what do you think is going on here? Let's say this is flip-flop reverse. Now it's a left-sided tumor. So what do you think this is?
The common perineal.
So remember we were sort of talking about her symptoms here being on the bottom of her foot. Probably tibial and common peroneal up here, splitting off.
Oh, I see.
So,
yeah, left side. Okay.
Yeah. Sorry, it's flipped. It's flipped because this isn't our actual imaging or our actual picture. So okay, so and you see they're doing stimulation testing. They're getting ready to resect this lesion. They find a good spot. They resect it, and I put this picture up so you can sort of see where that split is. And everything's better, and we send the pathology to Dr. Goltek.
As you saw in the radiology, it looks like a cystic lesion, and this is well reflected here in pathology. The top area represents the capsule, pink capsule, and inside you see a variegated appearance that represents the cystic spaces and a lot of macrophage infiltration, a whole bunch of degenerative changes in this tumor, which is typical when So here you see on the left part of the capsule, the fibroblasts and the collagen. In the middle, you see some of the rare areas where I can recognize this as a Schwannoma. It's a low-grade spindle cell lesion. It's trying to form Verroque bodies, maybe in the center, but yeah, not really super classic. Because of all the degenerative changes, it's difficult to recognize it as a usual Anthony A, Anthony B Schwannoma. with verrucate bodies. Next. I mean, it looks like a benign tumor despite all the necrotic cystic areas. These are all chronic degenerative changes. This is S100. S100 stains the, again, remaining areas of the Schwannoma cells very nicely. Next. On the left, you see transcription factor SOX10, SOX10, which is a nuclear marker of Schwann cells and also of melanocytes. But here we use to positively identify the Schwann cells. On the right side, you should remember that Schwann cells have basement membrane. So we exploit that as pathologists, and we show a basement membrane component called collagen type 4, which should stain every single Schwann cell. We used to do this by the reticulin stain in the past. So this also helps identify these as Schwannoma cells. Next, that's it. Okay, so this is a grade 1 benign Schwannoma with a lot of cystic degenerative changes.
I think they still actually refer to the reticulin stain on our exams because they're behind the times with the most up-to-date pathology stuff. So that's also a good thing to remember for the junior residents taking the oral boards, the written boards, that the reticulin stain is something that frequently does show up there to help differentiate schwannomas. So these are tumors of that are benign. They're from their origin is, of course, the Schwann cell. They show up in peripheral nerves, like this case, highly associated with neurofibromatosis type 2. Most are sporadic, and most of them show up around 50 to 60 years old. That age is younger in the neurofibromatosis cases. Here on these images that are just, I picked up, they're kind of showing the classic dumbbell appearance of the schwannomas. Most schwannomas are following along the peripheral nerves or cranial nerves, and so they're growing through different foramina, and that's what gives them this dumbbell appearance as they try to grow through these holes. They're almost like an octopus trying to get through a small space. They just contort themselves to that space and eventually expand it. But the dumbbell shape is very classic. Like Dr. Goltek had mentioned, these tumors have what are called Antony A and Antony B fibers, which I'll show a picture of in a second. And then also the other classic formation that he mentioned was the verrucate body, which we will I'll show next. So here you've got both types. You've got Antony A, the tight woven fibers, and Antony B fibers. So you have this biphasic pattern, very classic for schwannomas. Here is the verrucate bodies, which you see in the Antony A areas. These pictures are almost comical for how classic they are, but you see they almost look like large schools of fish swimming around in the ocean. That's kind of the pathognomonic way of describing them. But again, classic schwannoma shapes, and almost always on the boards for us. But don't get the impression that just seeing a biphasic pattern is going to be your kind of deciding factor. Is this a schwannoma or not? Because there are other tumors that have biphasic patterns. It's not just pilocytic astrocytoma, but there are others as well. There's gliosarcoma. There's various other ones that show up on our boards. So just biphasic alone is not a good differentiation. There's also mimics. So this is a scan in somebody with multiple tumors. And Turkey, what kind of tumors do you think this person has?
So differential diagnosis for this, lesion could be, meningomatosis, given the multiple lesions seen here in the posterior fossa. That's my number one.
Yeah.
Differential.
So I've shown you two pathology slides here that I've shown previously in this presentation.
Gotcha.
And this imaging. What do you think? If you could give a global diagnosis to this person, what would it be?
Yeah. So it seems that the path slide at the bottom looks like schwannoma. So he could be having both meningioma and schwannoma, given that the slide above is a meningioma pathology slide, and the one below is a schwannoma, pathology slide.
Yeah, and is there one diagnosis that ties those two things together?
NF2.
NF2, right? Exactly. So I mean, this is I found this picture. It's a pretty good one. I mean, it's you have bilateral acoustic neuromas here. You've got meningiomas. I mean, it's pathognomonic for an NF2 case. Again, meningioma up here, schwannoma down here. But easily you could have any one of the probably tumors like this in isolation. You might not be able to. I mean, these are pretty obvious, but sometimes you might not be able to tell if they're just very homogeneously enhancing. And so again, the pathology or the histology itself is kind of critical to telling the difference between the two, and they're very, very much different. Here's another one. So another thing that gets kind of that's in the differential for schwannomas, more so in the peripheral nervous system, is a malignant peripheral nerve sheath tumor. I'm showing two different slides. The big slides are the MPNST, and then the top right is your classic schwannoma. The kind of critical things with these is pain and weakness. They're the more common presenting symptoms for MPNST. And then on the histology, you see more tightly woven patterns. And then on the low power, which is the lower image here, you see what's called the marbling pattern, where they've got this, I don't know, it looks like marble, I guess, like stone countertop, marble countertops on the imaging. So just be aware of that. And then I can't remember if I have, I don't have any imaging of it, but you see more regular borders on the imaging. So they don't have that nice. Let's just go back to my old slide here. You see on this, where is it? This one, you see very clearly defined borders. It's very discrete. It doesn't have kind of this fuzzy appearance that would make it more likely to be a malignant peripheral nerve sheath tumor. Okay, very good. Last case for today. This is a case that I was asked to present. It's one of Dr. Morkos's cases. Kind of an interesting story. She's 66. She has a history of a right temporal tumor of some type, resected, that was in 2019. She lives in St. Thomas, so she went back. As far as we can figure out, she got no adjuvant therapy. She did not get chemotherapy. She did not get radiation. Completely lost a follow-up. She presented back to her PCP in St. Thomas with about 1 week history of left upper extremity weakness, kind of mild, 4 out of 5, no sensory deficits, and that's it. And they're asking what to do. They've sent the old imaging here, which shows this lesion. And let's see, who can we choose? Victor, sorry to bother you again. Are you still there?
Yep.
Yeah. What do you think? What do you think about this?
In short, it's a regularly defined right-sided temporal lobe lesion with associated edema, regular borders heterogeneously enhancing. It looks malignant, like a malignant tumor.
And just throw out a diagnosis for me.
Glioblastoma.
Okay, fair enough. Okay, and here's the post-op from then, and you see that the surgeon did a fairly extensive temporal lobectomy. I'm showing this image. What is this vessel right here, going into the transverse sigmoid junction and extending up here? The Sylvian fissure is kind of along here. This goes down to the transverse sigmoid junction. It's got another vein that comes up here like this that goes up to this superior sagittal sinus.
It's escaping me.
Lobé, the vein of Lobé. So they extended this. They extended this temporal lobectomy all the way back to the vein of Lobé, and it looks here like it's got a cut off here, but it's actually intact. It was actually quite impressive imaging, seeing how they'd gotten so close to it. They took a lot of the mesial structures as well. There's still a little bit left here, but otherwise, almost entirely of the temporal lobe is gone. Okay. So now we're back in 2021. Okay, it's been 2 years, almost 2022. So really 3 years, no adjuvant treatment, and she's got weakness. She shows up with this. Victor, what do you think?
Recurrence.
Okay. Yeah, I think it's probably the most likely kind of situation. Just a kind of a, I feel kind of obligated to discuss this, but these ring enhancing lesions. We talk about the importance of the imaging on differentiating between abscesses and metastases, and clearly you see the abscesses very much different imaging findings than the GBM. So what makes these two images different, Victor?
Restriction, diffusion restriction. Oh, you meant ones here?
Yeah. Well, yeah, it's a couple things. So I meant these ones specifically, but yeah, you're right. The diffusion restriction on the infection definitely is a huge differentiating factor. The border, how clear it is. This one's irregular. In the GBM, the amount of edema. I mean, all these things are kind of important things to recognize in the difference. Obviously, this case, the time course, this history, it doesn't really make sense. There would be an abscess, and what I'm telling you, but just a thing I had to mention. So she was taken for surgery, and they did again a wide as a resection as possible. At this point, though, it had gotten so big and invasive that they were forced to leave certain things. Victor, I'm showing something here that's been left over. What do you think this is? That's enhancing.
So could that be Sojusol?
No, something you would not want to resect.
That's a vessel.
Yeah.
The MCA.
Yeah, exactly. MCA. So you can see on this is a CTA that they did for some reason in the emergency room, and you can see as you work your way back how large a caliber of the vessel that is because of the amount of vascular recruitment. It's almost the size. It's bigger than the basilar. It's quite impressive compared. If you look left to right, there's a clear differentiation, and so they ended up having to skeletonize the MCA and leave what they could. And then here's the pathology that they sent to Dr. Goltekin.
So you're looking at another, I think, board image that they could, show in neurosurgery boards. You're looking at the palisading necrosis. On the left side, you see a cellular glioma. On the right and the top, you see examples of palisading necrosis in which the center is pink necrotic with, a shortage of nuclei because the tissue is dead. So you the dead center, the necrotic center, but flanked by this, intensification of nuclear density, and that's typical of glioblastomas. Although not specific for them, you can see that in an anaplastic oligodendroglioma or a medulloblastoma as well. But it's a good picture to remember. Next slide. Elsewhere, you see, extensive atypia of individual nuclei, enlargement, hyperchromatic nuclei, mitoses. On the left side, you see vascular proliferation. You can see that those nuclei are different than the right side, left and right. Left is vascular, right is glioma. So vascular proliferation, necrosis, mitosis, atypical glial proliferation equals glioblastoma. Anything else there? Yeah, so another example of vascular proliferation in this lower center. That's okay.
Yeah. Okay. So thank you, Dr. Goltekin. So again, this is GBM or WHO grade 4, very poor overall survival. They've frequently had this what's called the butterfly pattern. You see on this MRI scan on the right. This is an example. They have those features like Dr. Goltekin was saying: cellular pleomorphism, nuclear atypia, high mitotic count, macrovascular proliferation, pseudopalisading necrosis are all the classic features. And like he was saying, that picture, this one is really like a classic, could even be on our board's picture. And it really is, it's got all the features almost all wrapped up into one clean slice. So good one to remember. And I think I've got some other ones that look almost just like it. This is the kind of way that people categorize these tumors now from WHO 2016. You look at the first step is the histology, and GBM is very obvious based on these features, and from there they break it down based on the IDH wild type or mutations. There's other markers as well that are used to make different categorizations of the astrocytomas and the oligodendrogliomas, which we'll also touch on. There's also differentiation between primary and secondary glioblastoma. You see different markers in those, and there's different clinical histories. In primary glioblastoma, they're a little bit more aggressive. The history is a little shorter versus secondary glioblastoma. Important markers I've circled here, but the big ones are P53. You see a lot in secondary glioblastoma, and then also Mgmt promoter methylation, which we'll talk about in a second as well. So what is IDH mutation? Because we throw that word around a lot. The normal gene is for wild type, and it's a enzyme in the Krebs cycle. It's involved in aerobic metabolism, and it doesn't normally occur it occurs in all normal cells, but in mutated cells, which are only in tumor cells, it's theorized to participate in progression. But the wild type is actually associated with the poor prognosis. So anytime you see a tumor or a pathology report that says IDH wild type, that's bad. So in this case, the tumor was actually a wild type, both on the 2019 pathology and then the 2021 pathology. Mgmt promoter hypermethylation. This one was, I think, on both 2019 and 21 was hypermethylated. These tumors are treated with Temodar, with PCV if they're astrocytomas, and they use alkylating agents for this. So what that means is they're adding alkyl groups to the DNA, and there's an enzyme called Mgmt which is repairing these alkyl groups. So what happens is that these tumors that are Mgmt hypermethylated, that Mgmt is less functional, and so they have less of an ability to then repair the damage caused by the alkylating agents, and therefore they have a better response. So that Mgmt hypermethylation is a good prognostic marker, which this tumor also had, but again, she didn't receive any adjuvant therapy. There's these other markers, ATRX and P53, kind of help differentiate different types of tumors. This tumor was positive for both. One kind of thing to note from the prior slide with the choose your own adventure style differential diagnosis is that ATRX does not occur with 1p19q, and maybe Dr. Koltek can comment on this, but if there's a debate about whether this tumor is oligodendroglioma, which has a different histological appearance, versus astrocytoma, that if you're ATRX positive, you cannot, they're mutually exclusive of each other. You cannot be 1p19q co-deleted, which is pathognomonic of oligodendroglioma, versus ATRX, which would be more towards astrocytoma.
Correct. So ATRX loss is indicative of a molecular astrocytoma. Okay. ATRX loss does not occur in oligodendrogliomas. The molecular must-haves of oligo are 1p19q deletion plus IDH mutation. If you have these two, you have an oligo, 1p19q co-deletion and IDH mutation. That's an oligo.
Yeah, then that's the kind of thing that does show up on our boards. It's another one that you see it. It's those are kind of like low-hanging fruit for the boards. What else? So I guess they wanted this case presented because there were some questions about, how did this person survive so long? Because they've got a large mass, aggressive features on the first pathology. She got no adjuvant therapy. Granted, she had an excellent resection. I mean, you saw all the mesial structures were gone. So then people are debating, is that what was the original diagnosis? Is that correct? And I looked at the pathology report. It seemed pretty cut and dry. But Victor, I'm sorry. We'll go to somebody else. We'll go to go back to Eva. You there? Yeah, so I'm showing two slides, one of which on the right is this case, and the left side is a different case. Do these two look the same, or are they different?
I mean, it looks different. So on the right side, which is this case, it looks like the contrast enhancing borders are a little bit thicker. And then on the left, it looks like the contrast enhancing borders are just like thinner.
Yeah. So let's say, let's say you don't have any pathology. Let's say this person's, we didn't know who this person was, and she came from the islands and they didn't send any pathology reports. She had these images. She's got a right temporal lesion. She's lived for a long time without any adjuvant therapy. Throw out a diagnosis that a tumor that has a ring enhancing appearance like this, shows up in the temporal lobe, often presents with seizures that you might see in somebody with who has a longer overall survival.
Maybe like lymphoma.
Maybe. Thinking PXA, maybe. Seizures, kind of like giving it away. I mean, right temporal lobe, seizures, those kind of things kind of point as you want to throw PXA on the differential. And I'll ask for Dr. Goltekin's commentary in a minute. I've got different pathology slides on each side. These are the right side is actually from this specimen, I believe, and then the left side is just some examples of PXA, so you can see the difference. They have multinucleated giant cells, eosinophilic granular bodies, which you can see down here. And then they classically have this BRAF V600 mutation, which that again shows up on our boards now. I was kind of looking this up last night, and I guess there is somewhat of a difficult time identifying between this subtype of glioblastoma giant cell and PXA. I don't know, Dr. Goltekin, if you how you feel about that, or if that's true.
Yeah, well, definitely there is. It's a day-to-day problem for us. Both of them can be CD34 positive. Of course, there are anaplastic versions of PXA, which may even further complicate the matter. In PXAs, you do see on your left lower picture xanthomatous cells, but glioblastomas may have lipidized cells too. It doesn't help. In PXA, you do see eosinophilic granular bodies. That may be helpful. And of course, there is pericellular collagen and BRAF mutation. So if you see these, I think it's fair to say it would be an anaplastic PXA. And we also have epithelioid glioblastomas, which seems to be a continuity with, in continuity with the anaplastic PXA. So I think the problem is real, and it's something that we keep in mind every day. We try not to miss a diagnosis that would result in, a longer prognosis, and people would scratch their heads. Well, they said GBM and he's living 5 years. Typical situation.
Right.
So yes, I think it's good to emphasize that.
Yeah, and BRAF V600, you think is if you see that, that's automatically PXA and not GBM?
Once again, there is a variant of GBM called epithelioid glioblastoma, and I think it's really, in the spectrum of anaplastic PXA transformed into GBM, and that can have BRAF mutation. So BRAF mutation alone is not diagnostic or pathognomonic of any entity. But yes, of course, it contributes to, patient management, because there are BRAF, inhibitors that you can use to, help to carry the patient further.
Yeah.
So there's a gray zone in some cases. Let's put it that way.
I see. Okay.
Okay.
Well,
let me tell you this. If you find, let's say the histology is a problem. If you find EGFR amplification, P10 loss, so those would be more of a glioblastoma molecular phenotype. Okay.
Yes. Okay, yeah, I think this case it was pretty cut and dry with the pathology and the markers, but
Yes.
there was just more of an academic discussion about.
I would say that right temporal lobe location that allows the surgeon to do a more extensive resection may have contributed somewhat.
Yeah, of course.
Yeah. So.
Yeah, I think so, because that's why I showed that image, because they commented on the surgical report. They were able to go basically all the way back to the vena lavae and get everything, mesial structures, everything. I mean, she was just lucky that it was on the right. Okay, I think that's it. That's my references. I think that's it for today. Iggy, I don't know if you want to get the other presentation started.
Hello, everybody. My name is Christian. I'm a fourth-year medical student doing a Pseudo-Arthrosis here at University of Miami. And first of all, I'd like to thank the opportunity of being here and presenting my research project called Risk Factor for Revision Surgery in Hispanics who underwent non-fusion lumbar decompressive surgery, specifically for lumbar secretive herniation. This is a research project I've been working on with my mentor down in Puerto Rico, Dr. Jorge Laster. So just as a brief overview, lumbar secretive herniation results from the extension of this material beyond the limits of the intervertebral disc space, usually due to a defect in the annulus fibrosis, and is one of the most common conditions to perform a non-fusion lumbar decompressive surgery. The standard of treatment for lumbar secretive herniation is the standard open decompression, mainly that composed of discectomy and laminectomy. However, despite its benefits, revision surgery rates fluctuates between 5 to 23%. There have been previous studies that have demonstrated that preoperative, operative, and postoperative factors may have an influence in the rate of preoperation after lumbar decompressive surgery. However, the risk factor for revision surgery in the Hispanic American population remain unknown. So the purpose of this study was to identify those risk factors in this specific population. So here I present a single surgeon case control study of 345 patients who underwent surgery from 2011 to 2018 with a minimum follow-up of 2 years. Just as a presentation of the methodology, the total patient was about 345. They were split in two groups, those that were reoperated and those that were not reoperated. And the preoperative, operative, and postoperative data was analyzed and compared between both groups. Here are the results. So in terms of their demographics, we identified that patients who were female, retired, unemployed, or had a sedentary lifestyle were more likely to require revision surgery. In terms of comorbidities, we found a significant difference between both groups in terms of the presence of gastrointestinal disease. This includes peptic ulcer disease, gastritis, dysphagia, etc. Also, we found that patients who were active smokers were more likely to require revision surgery, the 30% in the revision group and 15% of the patients in the non-revision group. In terms of preoperative symptoms, we didn't find any difference between both groups. This includes headaches, sleeping difficulties, migraines, leg swellings, etc. No significant difference was found between both groups in terms of the preoperative physical exam. And in terms of the preoperative management, also there was no difference between both groups. And it's important to mention that between both groups, the lower extremity pain, radiculopathy, and bladder pain were the most common symptoms presented by the patients, which is usually what is described in the literature. Now, in terms of the operative data, no difference was found between both groups in terms of the estimated blood loss, length of stay, which was very similar, or the discectomy level. And also the L4-S5 and L5-S1 were the most commonly affected levels. And in terms of postoperative complications, we found that patients who eventually require revision surgery were more likely to have a wound adhesion. It wasn't like too many patients, but about, there was a significant difference between both groups. And in terms of postoperative symptoms, we found a significant difference in both groups, where patients that eventually require revision surgery did present with a worse had a worse clinical presentation with more lower extremity pain, radiculopathy, paresthesia, back pain, gait problems, and weakness in the lower extremity. So in conclusion, non-fusion lumbar decompressive surgery is an adequate treatment for Hispanic patients with lumbar secretive herniation. The overall reoperation rate in our study was low. It was about 11.3, which is comparable with other studies already in the literature. Therefore, L5, S5, S1 were the most commonly affected levels. And we found that patients who were female, sedentary, unemployed, active smokers, who had GI problems or disease, were associated with a higher rate of revision surgery. Also, finally, patients that underwent revision surgery were more likely to present more postoperative symptoms after initial surgery. These are the references. I'd like to thank everybody on the faculty, the attendees, and the residents for making this a great month. It's been a great experience so far. Yeah, and if anybody has any questions, feel free to let me know. Is there any questions? So that's all. Thank you, everybody.
I believe I'm up now for my presentation. I can go ahead and get started if everyone's ready.
Please do, share your screen.
Good, can everyone see me?
Perfect, you're ready to start.
Great. Good morning, everyone. My name is Frank DiStefano. I'm one of the fourth-year medical students here, participating in a sub-internship this month. This is actually my last week here, so I just wanted to extend a thank you to the department for the opportunity. It was a very welcoming experience here, and it was a very valuable learning experience at the same time. I wanted to give a short talk on some of the research that I did with Dr. Levy and with the help of some of the residents here at the University of Miami regarding bone morphogenetic proteins, more commonly known as CMP, and their use in spinal fusion surgery. Short background on spinal fusion surgery. We do about 400,000 spine fusion surgeries per year for the treatment of various disorders, including degenerative disc disease, stenosis, and spondylolisthesis. One of the major post-operative complications that we find is pseudo-arthrosis or of the vertebral segments. There's a few different risk factors that the literature has identified, some being patient-specific, such as smoking, chronic steroid use, and diabetes, and then as well as surgery-specific, those being a posterior approach and an increasing levels of fusion during a single procedure. This is a pretty poor outcome for patients. One study found that half of patients with a pseudoarthrosis diagnosis achieved satisfactory results with their procedure, in comparison to about 90% of patients who had a solid fusion. One of the ways that we combat or mitigate the risk of pseudoarthrosis is the use of BMP. which is a signaling molecule belonging to the TGF beta family. And essentially what this protein does is it recruits mesenchymal stem cells to the area of fusion, allows these stem cells to differentiate into osteoblasts and then increases bone formation. One of the more popular products on the market is recombinant human BMP2, which is the brand name being Infused, which is manufactured by Medtronic. It was granted FDA approval in 2002 for single level ALIFs, which is actually the only indication still for this product. However, it's grown pretty exponentially in its use, and it's used up in 85% of fusion procedures off label. Shortly after the approval of BMP, back in 2002, there was growing evidence of some adverse effects, particularly with the off-label use of BMP. One of the more popular concerns was dysphagia, dysarthria, and acute airway obstruction. Some of these patients needing intubation after ACDF procedures. This eventually led to a 2008 FDA black box warning regarding its use in ACDF procedures and a class action lawsuit that's actually still going on today. Some more notable other adverse effects that the literature found was urinary retention and retrograde ejaculation following ALIF procedures. Amplify, which is a higher dose BMP, was found to have an increased risk of cancer, which was later removed from the market. And then there was some various reports of heterotopic bone growth. A meta-analysis back in 2016 sought to investigate the dosages used in the neurosurgery community for these spinal fusion procedures. And what they found was it's quite variable between the same procedure and the dosage used in comparison to other procedure types. One of the more notable findings being that there's a 7.5-fold difference between studies using the smallest and largest reported doses. So with this information, what we wanted to do was take a look at the dosages used at our institution and see how those have changed since the FDA approval back in 2002. We also wanted to look at the complication rates and the fusion rates at the same time with these longitudinal trends in BMP dosage. So what we did was a retrospective analysis from 2008 to 2020 at the University of Miami hospitals and clinics, including Jackson Memorial Hospital, and we investigated patients that underwent spinal fusion surgery using BMP during this time. We collected various data, including demographic data, the procedure type that these patients went under, the BMP kit size, and then we were also able to estimate the dose per level by taking the kit size used and divided by the number of levels used during that procedure. We also took a look at complications and then the success of fusion assessed by postoperative imaging. And this paper was actually just recently accepted in August to World Neurosurgery and should be out for everyone to read fairly soon. So we collected just under 1,400 patients from 2008 to 2020. The first thing that we did was separated the patients into various procedure groups, those being an ALIF, XLIF group, a PLIF, PLIF group, a posterior lateral fusion group, and a ACDF group, and PCF, posterior cervical fusion group. The next thing that we wanted to do was take a look at the dose per level and the longitudinal trends of those over time in our study. For our cervical groups, we found that there was in our posterior cervical fusion group, there was a significant decrease from the start of the study to today. For our ACDF group, we did not see a significant decrease. What I believe is the result of this finding is, as you can see from 2008 to 2009, there was a significant drop in the dose per level used. And this is right around the time of the 2008 FDA black box warning. So I think that this had a very large effect on the results that we saw. For our lumbar procedures, we did not see a significant decrease for our ALIF XLIF group, but we did for our PLIF PLIF and then our posterior lateral fusion groups as well. For the ALIF XLIF group, This is the only group that actually has a FDA approval for, and what the FDA studies were granted on. So I believe that that had a large effect with it, that this one had the most data to back it up. The next thing we did was look at complications. We had 152 total complications in the course of our study. The ones in bold were used for further analyses, and we picked these ones specifically because the literature supports that BMP may have something to do with these complications. The ones not in bold, we did not think were feasible, that they would be causative from BMP, and they were excluded from the further analysis. So for our complication rates, we did see a decreasing trend in complications from 2008 to 2020. And then we also ran a logistic regression analysis to see, to investigate the BMP dose per level. We did find that it was a significant independent predictor of complication. We also checked and investigated to see if procedure type had anything to do with the complication rates. However, we did not find any significant findings. The next thing that we looked at was fusion rates. These were assessed by postoperative CT with a range of 16 to 14 months postoperatively. And we found that the fusion rates remained stable pretty much across the board for all procedure groups. We also found that the posterior lateral fusion procedures demonstrated the lowest fusion rate. So some of the conclusions from this study was we were able to, one, make a retrospective study analyzing dosages of BMP used at our institution over the course of time. We found that our posterior cervical fusion, PLIF, TLIF, and posterior lateral fusion groups did see a significant decrease over time, and we did not see that in our ACDF or ALIF groups. We did see a decreasing trend over the course of time for our complications, and found that the dose used per level is a significant predictor of complications. And then also, as regarding fusion rates, we found that they were fairly stable over the course of time. Some of the limitations of the study would be retrospective design in nature. This is also just one institution, so I think if we had multiple institutions, it would be stronger. I think a bigger, one of the larger limitations would be the complications. It's very tough to say that the decreasing trend in BMP would be causative of a decrease in the amount of complications. I think that 12 years is a fairly long amount of time, and I think that just in general, spinal fusion surgery has gotten better in our craft and has had less complications. So that would be kind of tough to delineate if the BMP is the causative factor. I think also the application of BMP is fairly imprecise in the OR. And you can do best to kind of estimate the pieces that you're putting into the interbody devices or between the facets, but it's still an imprecise application. Some of the future work I think would be interesting is obviously bringing in multiple institutions, maybe finding a better way to apply the BMPs so that we can better accurately study it. And I think a cost benefit analysis would be fairly interesting because this is a fairly expensive product that is used quite a bit. So it has a pretty high cost to it. And then also I think some of the newer technologies listed below, I think it would be very interesting to do like a head-to-head as far as complications and fusion rates. Thank you. And then I'll also take any questions.